Okay, and now we're going to do orthodontic care for the lecture. And this is based off of chapter 40 in Darby and Walsh. So the objectives for this lesson are to discuss malocclusion, including the effects of malocclusion, assess and evaluate the need for a referral for orthodontic care, educate patients and guardians to understand normal developmental changes versus orthodontic needs, and describe various orthodontic considerations that affect dental care. Describe the biomechanics of tooth development. And describe the 3 types of orthodontic treatment. Detail the uses of a variety of orthodontic appliances. Identify risks associated with orthodontic treatment and communicate how to mitigate or manage the risks. Discuss the need for dental collaboration when dealing with alternative orthodontic treatment to address restorative, periodontal, and implant needs. And finally, instruct patients on effective self-care regimens. So the goal of orthodontic care is to gain or maintain normal functioning of the occlusion, improve aesthetics, and promote long-term health and stability. Also, to maintain the temporomandibular joint health and to avoid temporomandibular dysfunction or temporomandibular disorders, and establish or maintain periodontal health. So tooth movement can improve all of these areas. And if there's malocclusion, it can worsen some of these conditions. So the American Association of Orthodontists recommend that an orthodontist examine a child by the age of 7 years. The best plan is to assess young children, ideally by 7, to begin to observe and document issues that may start to arise, referring the child to an orthodontist to start planning. Early interception and planning I guess I feel like the word should be intervention, not interception. But anyways, early intervention and planning can lead to higher treatment success. So posterior occlusion is established when the first permanent molars erupt, and it's at this time that basic occlusal relationships can be evaluated. So that's why 6 or 7 is probably 7, just to give everyone enough time, is the best time. Incisors have begun to erupt, leading to identification of crowding or a deep or an open bite or other jaw discrepancies. For some, early detection and interceptive treatment can lead to more effective treatment plans. Malocclusion is not a disease state, so it's not a disease to have malocclusion. Rather, it's a deviation from the normal relationship of the maxillary arch or teeth to the mandibular arch or teeth. And that's what malocclusion is. It's any deviation from what's considered normal. So there can be genetic discrepancies, or there can be trauma or parafunctional habits as well. And if we read a little more in the notes here, it says these genetic discrepancies can be either skeletal or dental. Some examples of genetic malocclusion are overcrowding, supernumerary teeth, a narrow jaw, and premature or late exfoliation. An example of strictly dental malocclusion is individual tooth placement or tipping of teeth within the arch or a posterior crossbite. Those are strictly dental malocclusions. Examples of parafunctional habit include thumb sucking, clenching, grinding, and other habits outside of the range of normal speech and mastication that affect normal growth and development patterns. So here we have this great, where did it go? Go back. Here we have this great slide that helps remind you of class 1 occlusion. We have the maxillary first molar mesial cusp in line with the mandibular first molar buccal groove. So the mesiobuccal cusp of the first molar is sitting right in the buccal groove of the mandibular first molar. That's class 1. Now, class 2, division 1, we have the mesiobuccal cusp is anterior to the buccal groove. So it's anterior, it's moving forward. And class 1, we have sort of this jutted out teeth, almost like a Bucky Beaver kind of look to it. The teeth are sort of pushed out. And in class 2, division 2, we have the same thing, mesiobuccal cusp anterior to the groove of the mandibular first molar, but the maxillary teeth are not jutted out. They're kind of crowded and maybe even pushed in a little bit. And then in class 3, we have the mesiobuccal cusp of the maxillary first molar is distal to the buccal groove of the mandibular first molar. Hope I said all those words right. Sometimes you say it and then you think, what did I just say? But the maxillary mesiobuccal cusp is distal to the buccal groove of the mandibular first molar. And that gives you sort of the bulldog, the jaw, either end to end or the mandibular teeth come in front of the maxillary teeth. Effects of malocclusion. So effects of malocclusion, psychosocial problems caused by poor facial aesthetics, poor word enunciation, oral function problems such as difficulties chewing, swallowing, and speech, increased plaque, biofilm, debris, and stain retention contributing to periodontal disease. That's giving, such as gingival recession, mucogingival problems, and alveolar defects, or the bony defects, injury caused by trauma to break or malpositioned teeth. And then TMJ dysfunction, chronic impairment, discomfort, and function of the TMJ, the temporomandibular joint. So what are the effects of malocclusion? Just to read the notes here, it can have psychological effects, oral functioning problems, difficulty cleaning, removing biofilm, and other debris, tissue trauma, or chipped or broken teeth, TMD, or pain, to name a few. Better summary there in the notes. Okay, so here's some images. Our series of intraoral photos are an excellent resource to identify a need to refer to an orthodontist or for malocclusion. Radiographs also tell us a lot about development, supernumerary teeth, congenitally missing teeth, or impacted teeth. Lateral cephalometric radiographs and cone beams, the CBCT, computed tomography, CBCT, that's the 3D imaging, are typically taken at specialist office. So generally speaking, that won't be taken. These images here will not be taken at a general practice, but I do think more and more they may be, general dentists may have CBCT machines. Here's just your typical pano, and then this is the lateral cephalometric is what it's called. And then here's your intraoral series that we do. These are so pretty. I don't know how they get them so nice. Okay, so when to refer to a specialist? If there is lack of adequate space in the arch, if there's interference of delaying permanent tooth eruption, if there's altered sequence of eruption, that is really important to note. If you know what should be coming up and the normal expected teeth are not coming up, there's an altered sequence, that's really important to note. Over retention of primary teeth, early loss of primary teeth due to caries or trauma that could cause malocclusion and problems. Supernumerary teeth, most commonly found in the maxillary anterior, and this is not always a problem, but it can be. Congenitally missing mandibular second premolars and maxillary laterals are the most common. If there's crowding of the primary mandibular incisors, so we're talking baby teeth. If there's crowding in the baby mandibular incisors, that foreshadows not a good sign because if they're already crowded in their baby teeth, then you know they're going to have major problems and crowding in their adult teeth. If there is severe crowding during the mixed dentition, that's a good sign that the patient should be referred to a specialist. If there's a midline diastema, this may not be an issue. I have a big old diastema, and I never needed ortho, but it's something to think about. Impacted canines, lack of leeway space. And this is the additional space, the leeway space, or sometimes it's referred to as the E space. It's on average 5 millimeters in size on the mandibular arch and 3 millimeters in size in the maxillary arch. So this is a space in primary dentition, the leeway space. And so if there is no leeway space, then that may indicate an issue down the road. Protruding maxillary incisors, often caused by habitual thumb sucking, temporomandibular joint dysfunction, or signs of TMD, clicking, pain, restricted range of motion, etc. Biological mechanics of orthodontic tooth movement. Okay, so what's happening? This occurs when light pressure is exerted on the tooth. So emphasizing light. Bone is being resorbed on one side of the tooth, and new bone is growing slowly and hardening on the other side of the tooth. Orthodontic appointments are typically made no more than 4 weeks, every 4 weeks, to allow for healing and prevent damage to the tooth or the bone or the root, because we know we can have that root resorption. So here we have the orthodontic force is coming in here. There's tension on this side. And so new bone is going to form on this side, because you can see how the ligaments are being pulled. So slowly new bone is going to form. And then on this side, there's compression and the bone is resorbing. Thus, it's allowing the tooth to move to the side. So after 6 hours of sustained pressure, cellular activity in the PDL includes differentiation of osteoclasts and osteoblasts occur. This is that breaking down and building up of the bone. Tooth movement will occur about 10 days after activation. In another 10 to 14 days, repair and regeneration of the PDL occurs. So describe the effects of orthodontic force on the teeth and the periodontium. So the effects on the pulp is minimal, mild transient pulpitis first few days due to initial activation and pressure. Loss of pulpal vitality could occur from previous histories of trauma or poor control of the orthodontic forces. So if the orthodontist is trying to move something too quickly, that could lead to more serious problems. Effects on root structure: normal resorption and repair of the dentin and cementum occur during treatment. Apical root resorption, loss in the length of the tooth, length and apical blunting. This is apical blunting here. That can be from too fast of movement. And maxillary and mandibular incisors are most commonly affected. To help prevent, the orthodontist should use low force wires, brackets placed low on the tooth. So see how high this is on the tooth? The brackets should be placed lower on the tooth, and move the teeth very slowly. Effects of the height of the alveolar bone, so the bone in between the teeth. It's not affected negatively unless there's active periodontal disease, and the bone may increase if the tooth is being moved to an upright position, so it may actually help. Describe the effects of orthodontic force on the teeth and periodontium. Okay, effects on mobility and pain. Increase during orthodontic treatment, widen PDL. So there's going to be some mobility and some pain for sure. If excessive mobility develops, may indicate too much force and thus may cause too much undermining and bone resorption. After the initial adjustment, may experience pain to chewing, sensitivity to pressure for a couple days. Just think about how your teeth sometimes feel a little sensitive, just like there might be a little achiness in your teeth after you get them cleaned. Well, imagine how you can have achiness in your teeth after they've done some active movement on your teeth. It is more comfortable for the patient to have a routine dental cleaning immediately before adjustments, not after. Scaling particularly can be uncomfortable right after adjustments. I always tell this story because I didn't really think about this when it was happening, but now that I go through this lecture, I'm reminded of this little boy who had just had his brackets adjusted. So he had just either the day before or earlier that day, he'd had his brackets tightened or adjusted, and he was uncomfortable, and he came in for a cleaning. And I was trying to be so gentle, but he was just sitting there with tears running down his eyes. And I didn't understand how it could hurt quite so much. But now that I, have learned and relearned, and remembered this stuff from this lecture, I look back and my heart just kind of sinks. I should have told his parents to have him come back like in a week or reschedule for a couple weeks, that it wouldn't hurt anything and he'd be a lot more comfortable. Effects of orthodontic force on the maxilla. Areas where growth modification may be effective are the structures where the maxilla is attached to the cranium and the mid-palatine suture area. So that's where you can either, palate expanders, grow the palate, especially if there's a narrow palate. More growth hormone is secreted in children during the night than during the day. That's why they encourage the headgear to be worn at night, because that's when more growth hormone is secreted. We can have gingival recession can be an issue, depending on how much bone there is, the thickness of the bone from front to back, and where they move the teeth. They can actually move the teeth out and right through the bone. So this isn't necessarily from like brushing too hard. It's just simply from moving the teeth out and there not being enough bone up here. Gingival overgrowth, you can see how the gingiva gets real puffy and bigger, and it's like fibery. It's not like necessarily spongy, it's like fibery, and it's from this trauma of, the tooth movement and the brackets. Decalcification or the white spot lesions, this is permanent. And so if the patient who has the brackets are not doing a really excellent job of removing the biofilm, brushing and flossing and removing that biofilm, they will get demineralization. And even if that demineralization does not turn into full-fledged cavities, if it remineralizes, it will leave white spots, and it can leave white spots all around where the brackets were, where the teeth were constantly getting demineralized. So that's why it is so, so important to stress this to our patients so that they know to prevent it, so that their teeth look really pretty when the braces come off. They don't look speckled. Okay, so removable appliances, growth modification in adolescents and in children. There's functional appliances used during growth modification, modify the growth of the mandible by stretching the soft tissue that surrounds the mandible. There's limited movement of the individual teeth. So things like these, Invisalign or the clear correct, the ones that you change out. The aligners are worn for most of the day. You have to wear them for 22, plus hours. You basically only take them out when you're eating. For 2 weeks, and then you get a new aligner, and you go through this long sequence. It may be used in combination with other therapies. Retention after treatment of completion, usually there's still either a fixed or a removable. And this clear aligners or the Invisalign, it can be a quicker process, but not necessarily. My daughter had just a very minimal, it was more purely cosmetic than anything, movement with the Invisalign, and she was in them for basically 2 years. So, and she still has the removable retainers. So then there's fixed appliances, consists of bracket or other attachments that are fixed to the teeth with bonding and attached to bands that are cemented to the teeth. There's separators and bonded attachments. So here's some different images of things you may see, these big old arms. I've tried to clean around many of these. These are very hard to clean around. You just absolutely do your best, get out. You end up using proxy brushes, N-Tuff brushes, the ultrasonic, more than hand scaling when you see patients like this, because a lot of times they don't necessarily have lots of calculus, they just have lots of plaque buildup. And so you use anything you can to get around these areas. I usually would start with the ultrasonic on a low level, just try and flush off all the soft plaque. Then I would go in with proxy brushes, I'd go in with N-Tuff brushes, I'd go in with, the floss threaders. The floss threaders can be really challenging though. They get hung up and tear and snare, and you just honestly do the best you can. And you realize that if it's a struggle for you, it's a struggle for your patient, and they're young. They don't want to, necessarily do all this. So you just really get creative about encouraging them to use their water picks and to use proxy brushes and to brush after every meal, just so that they can get as much, plaque off as they possibly can. Here's palatal expanders and little localized expanders here. Here's some more different images, some retainers. This kind of opens up the bite a little bit, all different sorts of things. And you won't be an expert on these. You may not even know necessarily, like what you're looking at, but you can talk to your patient and say, oh, what are they doing this for? Or call the orthodontist and say, can you give me a little rundown on what's in my patient's mouth, and then you can also do some research if you see something, because orthodontia is it's changing, and they get new things, that they implement. And so, there's always stuff to learn. There's the clear aligners. These are the little buttons that they put on the teeth. They just glue these down, and they help put force in the right area that they want the force to help move the teeth, and the aligners just pop in and out. And here are some retainers. You will see all different kinds glued to each individual tooth, just glued to the canines, just through the incisors, or just on a couple teeth, or removable. Or if it's Invisalign, it will just look like this again. They'll have retainers that just look like that. So here's just a diagram, talks about the bands, the wire, the rubber bands that they put in the mouth. All these little rubber bands around the brackets. Elastic ties, the hooks that can hook on, they might have a rubber band going from here to here, or from here to here, all different things. And then the brackets themselves, these bands surround the entire tooth. They're like usually stainless steel that surround the whole tooth. Different colored elastic bands. They can have clear brackets, metal brackets. They put in these little buildups to get the teeth to occlude differently, or to give some space between the teeth. There's just all different sorts of mechanisms. They have brackets on the inside instead of the outside, maybe more aesthetically pleasing. I don't know if it's harder or easier to clean, but I have seen one patient with that, brackets on the inside instead of the outside. So what's our role? So we're kind of there to be like a partner and a cheerleader for the patient. We want to help them understand the importance of prevention. So to motivate, to educate. Self-care is a challenge with orthodontics, and it's usually a young population that might have a harder time being motivated. Patient is at moderate to high risk of caries. So automatically, if they're in your chair and they have ortho, they're at a moderate to high risk. It's difficult to access around the brackets. It's hard for us as dental hygienists. It's hard for the patients. Compliance with oral self-care can be low, so we have to be patient with these patients, but be very encouraging and talk to them about their risk of caries. Adverse effects of the poor biofilm control. So here's all this is just, all the stuff we need to know for pretty much everybody. But toothbrushing, they can use a 2-row sulcular brushing. So there's toothbrushes on 2 sides, and it cases the teeth, or encases the brackets, actually, should I say. So it cleans above the bracket and below the bracket. There's middle row of bristles that are shorter to facilitate use over the bracket. They can use end tuft brushes for around the brackets, powered toothbrushes with a timer, interdental brushes, rubber tip stimulator. There's the platypus aid, the floss aids, the floss threaders. A water flosser is really good, super important. Chlorhexidine to control the gingival inflammation, and use interproximal brush to treat localized areas to prevent staining. They can dip the proxy brush in the chlorhexidine and then go interproximal if they don't want to just rinse it everywhere, because that can lead to a lot of staining. Fluoride therapy, they can use the prescription toothpaste or the gels. Dietary counseling, sugar intake minimized, limit to mealtime to reduce the amount of acid attacks. Food that can't be cleaned off appliance may lead to caries, white spots, unattractive food debris accumulation. You've probably seen kids who are doing a really bad job brushing, and all their lunch is packed in around their brackets, and you think, don't you want to get rid of that? And you can help motivate them and help them see what they can do. Don't overload the patient with too many products. So obviously you don't tell them to do all of this. You just give them one or two things, especially if they're very, very not motivated. Give them a few things to work with, and you can build on it if they start making progress. Make sure patient is in agreement with the maintenance routine, and discuss dietary choices. So here's just images. Here's a really thin brush that can brush above and below the bristles. Here's these, I love these little tepe brushes, or end tuft brushes by Gum Butler. Platypus is meant for brackets. I've never thought it worked as great as they show it, but some people do like them. And water pick for sure. Flossing underneath all sorts of stuff, even like this palatal expander. Proxy brushes in all the different areas, different sizes. Professional fluoride application, maybe every 3 to 6 months. Ultrasonic air powder polishing, you can do that. Use a cone-shaped prophylaxis cup. So you know how we have our normal rubber cup? Well, you can also have some cone-shaped ones. I used to have one of each on my ortho tray, because the cone shaped gets in around the brackets better. Increase the prophy frequency to 2 or 3 month intervals if you have to. I mean, remember, I think I've talked with you guys before, you don't have to stick to 6 months just because they're a kid. They can come in 3 months, 2 months, depending on what their need is. You can see major gingival inflammation and hyperplasia in this. I mean, they just absolutely grow right down to the brackets. You can see this decalcification, a major inflammation. You can see the root resorption, aphthous ulcers. You can use a little bit of wax over the bracket that keeps rubbing and causing a kink or sore, and then dental caries. So these are all things that we have to think about for our ortho patients. And last slide, communicate with the orthodontist. Any problems with the ortho appliance, loose brackets or bands, wires impinging on tissue, extreme mobility or unstable periodontal status, send radiographs that have been taken, read any letters that have come from the orthodontist to see what they did on their end, monitor for relapse, wearing of retainers, compliance, and how often they're doing what they're supposed to be doing, if they're complying with all the instructions. And you can take x-rays when there's radiographs. Sometimes you can't see interproximal decay as well, but you can monitor bone level, and if there's decay that's growing that you can see. So it's not a bad thing to take radiographs. And if you have an adult patient, be more mindful of their periostatus. Kids, it's important too, but I've had perio patients in braces, and you have to be very, very careful, and they have to have excellent oral hygiene, because they're just at so much greater risk. So that's it with the orthodontics. I'll see you guys later.